So we are recording now. But okay, who has questions for Kelly? Kelly, that was awesome. Great job. Great job. We had a good comment in the chat from Jennifer Fike about having the provider write down a very specific letter and also being available basically 24/7, it looks like, with their contact information. Great comment there.
Jennifer, who do you work with, if you don't mind me asking?
I used to work with Dr. Mary Jo Cannon. She's in Cumberland, Maryland. I don't work with her currently, but that's who I used to work with.
I was trying to remember. I've had one person, it was like when I first started at WVU as a midwife, that came with the most beautiful written letter from her prescriber that had very clearly detailed things with like the dose and contact information. And I was like, man, this is amazing. This is how it should always be. It was brilliant. I think it might have been out of Cumberland.
Any comments or questions?
I'm just going to comment. I do think this piece about communication between provider of MAT and OB is a challenge and may differ depending on the setting. I mean, even before Kelly was our prescriber, I would upload a letter into Epic for the providers on the OB side to see. And, you know, when I queried people about, did they ever see the letter? They never read the letter. They never saw the letter. So I may put in effort to make that communication, but the communication failed anyway. And so making sure you're sort of figuring out the system that you work in, what is the best way for this information to get shared? Because it may be a little bit different depending on the setting you work in.
Thanks, Laura. Did we have a comment in the chat? Do you see it, Kelly? Do you need me to read it?
I can see it.
Okay.
It says, is there anything specific that should go into that letter? Which I was actually typing out a response. So I would say from a prescriber, I would want to list out like the prescriber name, where they're established at, the phone number to the clinic or to the person that's providing treatment. Obviously medication and dose. A huge thing that's really helpful is frequency, or like how that specific person is taking their meds. Something that I notice a lot on admission to labor and delivery is we'll call and we'll verify from an outside place, like, okay, she's taking 16 milligrams daily. And then you actually talk to the person and they're like, well, I mean, I actually end up doing like, it's 2 films a day, but I end up doing half a film every 6 hours. And then you're in this weird state where you can only prescribe and order what is written from like confirming at the clinic. And then that can be really hairy, because then it looks like the person is being like non-compliant, which is one of my twitchy like words that I hate to even hear people say, that they're not taking it as prescribed. They're taking the same daily dose. There's just a disconnect between what they have documented that they're doing and what they're doing. So that can be really helpful. If you as an MAT provider have specifics on what you do or do not want, or what you've discussed with your client, like taking and accepting during labor. So I've had MAT providers send letters that they under no circumstances want their person receiving opiates. Then that's really helpful to have. Or I've gotten angry phone calls from prescribers before who have said, why did you give my person fentanyl in labor? What is wrong with you? So if you are an MAT provider that has those concerns and that you don't want your person in treatment getting those, just making sure that's clear.
Awesome. Thanks, Kelly. If you want to put that response in the chat as well, we'll make sure that that gets out to everybody in the notes and things like that. We've got time for one more question or comment if anybody has one.
I thought it was important that you noted the documentation to make it clear what mom received during labor and delivery because of the CPS issues. And that can be detrimental if they see that in the record that mom tested positive for fentanyl, but if she if they don't know that she received that during labor, then that can make a huge difference in the case.
Absolutely. And I think that kind of to stem a little bit off of, to swing back to what Laura mentioned, it is not an uncommon thing for people to come to their birth with a birth plan, which also, don't get me started on the stigma around birth plans, but that like we see a lot. But you can do a birth plan with what you want for your pain management on MAT. So that's where I can see like a letter from someone that's working with the client regularly, like having them bring it in. The ones that I see always get like noted by staff as if your person comes in labor and is like, oh, here's my birth plan. Like, oh, here's like my treatment plan for pain or my pain agreement. So that's something that you don't have to scour through the chart and look for, and that they have if they just have a copy of it. Or if you're a facility that's using Epic, they have sticky notes, they have problem list. I know all the OB providers at my facility do use the problem list quite frequently. So if you drop in the problem list in media tab, like letter from prescriber is scanned in, then that's something that can be really helpful. Something else in the chat is making sure that drug screens are confirmed and not just a screen. That's a huge piece as well. Sometimes that gets missed on things getting sent out for confirmation. I know the screens at our facility aren't perfect. So if you're on Synthroid or labetalol, sometimes it'll make your screen pop positive for other things. So always helpful to send those for confirmations. NAS discussion with mom before delivery is also a really good point. That was in the chat, making sure they know what length of stay is and what they're looking at.
Great. Thanks so much, Kelly. We're going to go ahead and switch over to the case, but thank you so much. Again, sorry for not recording the great presentation, but we will get the slides out to everybody. I'm going to go ahead and share my screen, and Jennifer, I will scroll through the case as you go through it, but I'll turn it over to you.
All right, thank you. So I'd also like to recognize Rhonda Edmonds, who just shared a very insightful comment with us a few minutes ago. She polled her staff, and we worked on one of the case together. So this is a former Lily's Place client. Our main concern, we'll kind of start with that before giving the details, is how can we get this patient, how can we help this patient to get optimal NAT to improve her overall stability. And I want to emphasize, like, this is coming from the perspective of a PRSS staff. So as a member of the treatment team that is not directly providing the MAT, how can we advocate for this patient? So this patient is a woman in her late 20s. She established at Lily's Place 3 years ago following the birth of her youngest child. She was on buprenorphine only and stable in a program during that pregnancy. She successfully completed a CPS case despite numerous stressors. However, she received minimal support once her case was closed. This case in particular was in one of our surrounding counties, not the county where our facilities are located. And so she really did not receive a lot of support from the CPS in her county. She did a lot of meeting her objectives, such as obtaining employment and housing, on her own. And then when her case was closed, effectively did not have any of that support from the CPS system. Her informal support system is not really sufficient to help her stay on her feet. So her own mother has active SUD. The patient is a single mother, works full time, has 4 children, has no transportation. She does receive MAT at a local private practice. In part due to the stress of reunification in the context of low social support, the patient began taking her prescribed buprenorphine intravenously in order to experience the psychological effects of that. Patient's prescriber, in an effort to assist her from the temptation of using her films intravenously, changed her to Sublocade. This patient is fortunate in that her insurance actually pays for Sublocade, which we have a really hard time getting paid for down here. However, the Sublocade has to be filled by a special pharmacy, and on more than one occasion, this pharmacy has failed to provide the product to the provider in enough time for her to get her dosage on time. So she's experienced some breakthrough withdrawal. This patient is HIV positive and Hep C positive. As far as we know, she's not been diagnosed with any psychiatric comorbidities. Relevant physical exam results, she's experienced withdrawal between doses. And as far as we know, she's only on Sublocade. Is that the end of the form, Jay?
Sure is. Yep.
Okay, so we did a little bit of brainstorming, but I might save that till the end because I'm really open to any kind of guidance from other programs. If this was your patient, what would you do to advocate for her?
Hi, it's Dr. Wonder Genus. So how is her housing situation? Is she in stable housing, apart from her mother and limited support? Does she have any community support? Does she go to NA meetings? Does she belong to a church organization that could possibly give her some additional community support?
So she does have her own housing and she is employed, and she's clearly a very hardworking individual. I mean, she's walking everywhere and she's been able to maintain the progress that she's made in terms of her, her social role functioning. That would be a good next step, I think, for us to gather additional information about what other supports she may have available that she's maybe not utilizing yet.
Would she be interested in naltrexone?
So that would be, I think, a good question. Can you explain though, just kind of as like a learning experience for myself and everybody else, like what's your thinking with the naltrexone?
Naltrexone is just another option that we have in light of a client no longer actively using and has been stable on an MAT program for several years. If you can get them low enough, you can actually get them off of the buprenorphine altogether and try this alternate non-narcotic, non-opiate agonist option, which obviously then would take away the opportunity for her to use that IV or any other way to get that psychological high.
Yeah, so to reduce kind of the possibility of misuse. Also, at least in our catchment area, it's a lot more accessible. A lot more pharmacies have Vivitrol available. Has this happened to anyone else? Not being able to get Sublocade from the pharmacy?
Yes, so we have, not specifically to Morgantown, but we have folks who come and are started on Sublocade in our 28-day program at Center for Hope and Healing, and then they get discharged home, and in their home community, they cannot get Sublocade. I mean, it may be covered by insurance, but finding a pharmacy and the logistics of the pharmacy, getting it to the prescriber to administer it have been a challenge.
Have you made any headway with any of those folks, or are they usually changed to a different medication?
So this actually just came to my attention recently because we do okay in Morgantown. Our folks have sorted that out. I'm very grateful for that. But in some of the more rural communities, I mean, it's all new. And so we're trying to work with, individuals in more remote locations to see what they can do to partner with pharmacies in an effective way so that patients can get medication. But it feels relatively new and people are still figuring it out. But it is important. It was important for us to communicate to our 28-day program, hey, you need to consider this. Where is the person from before initiating Sublocade, because it may not be the best medication fit for them.
Any other thoughts on where you might start with kind of assisting this patient work through this problem?
Don't be shy now. We had some good conversation there with Kelly and don't be shy. Feel free to use that chat too if you can't unmute. Totally understandable.
I think the other thing I think of is and this sounds very basic, but like, how is that medication getting ordered over to the pharmacy? So if it's something where they're only getting a short notification, like, oh, it's a couple days before and I need to like get this order in for this person, that's going to be harder for them to get. I know I've had that issue with people who are on like the 2 milligram films where they have a hard time getting the appropriate quantity from the pharmacy, where if they do have that advance notice and that regular notification that they're going to need that and that timing, that can be beneficial for pre-planning. So it can sometimes be something as simple as a workflow like that.
Yeah. The other thing you may want to consider is working with a kind of like a distribution pharmacy that'll deliver it directly to your office. So WVU's Allied Pharmacy, I don't know if they'll do it. We work with, not for this, but for other things like McKenna, they deliver it directly to our, there's a pharmacy, like I think it's in Wheeling or something like that delivers directly to our office. So that may be something, if you have the facility to store the Sublocade and have a protocol for that, then that may be an option. Or working with a smaller local pharmacy. Sometimes the independent pharmacies are more willing to work with you. Sometimes they're not. The opposite can happen, but I find a lot of times the chains, they've got, controls, they've got amounts, they're not very flexible, staff changes versus some of our smaller pharmacies in the community, especially like that. You can go pick it up, they can deliver it to your office, that kind of stuff. I found a lot more helpful. Or kind of one of the centralized pharmacies that do kind of the McKenna, they do chemo, those kind of things often may be helpful too as well to get her medication.
Yeah, that's great.
Anybody else? That was a great comment. Dr. Baltiera, thank you. Well, if that is it, I think Jennifer, thank you so much for the presentation. We'll get some of these points put together for you and sent back to you. So hopefully that'll help you moving forward.
I'll share with the group that really the first thing that when I spoke to the staff at Lily's is if we don't already have a release on file, to speak with the private practitioner who is providing the MAT, that we need to get that as soon as possible, so that they might be able to make a direct call over there to see what's going on, and if they have their own recommendations coming from, I'm really mostly used to people taking sublingual bupe, but there have been times where we've had to advise patients to switch their pharmacy, or to use a pharmacy that's going to reliably have the medication in stock for them. So there may be things that the practice could do if, maybe just with a little bit of advocacy on part of the PRSS. So thank you, everyone. I really appreciate all the feedback. As Laura mentioned, this is kind of a new problem because for the longest time, we couldn't get anyone to pay for it. So it wasn't a problem before.
Okay. Let's see. So just we can do a couple of housekeeping items here and then we can get people on their way. But our next session is going to be on May 9th. So be on the lookout for reminders and everything about that. The evaluation link has been put in there by both Lynn and Jennifer. So you guys should have that. That'll also be in the recap email for the evaluation of today's session. Obviously, submit cases. Please, you can see that what Jennifer's case was very short to the point. You know, it doesn't have to be a novel or anything like that. So please, please submit cases. If you have any issues with submitting them, or you just have questions before you submit one, please don't hesitate to reach out to us. We can really help you and make it as easy as possible for you. And then the last thing I want to just remind everybody is with the link for the sessions. So I saw a lot of people kind of pop up in my email as things were going on today about re-registering for the event so you could get the link. In that confirmation email that you used to join the session today, if you re-registered, there is another link in that email to save it to your calendar. And it has options for like if you use Google Calendar, Outlook, and so forth. So please go back in there and add those. That will populate every session that we have so far, so you won't have to re-register or go through, digging through all your emails and things like that. It is a little quirky with Zoom where they just won't automatically do it. Hopefully the next update to Zoom that they'll take care of that. But for right now, you have to kind of physically go in there and click on the add to calendar button.
Hey,
Gotcha.
for myself, I got a notification that there was maybe an update to Zoom since our last session, and I think that's why I had to re-register.
Oh, okay. No, that's new. Okay, so if you are having the same issue as Jennifer, then yes, please re-register if you cannot absolutely do that. But hopefully now you will have the confirmation email to then add it to your calendar after updating your Zoom and re-registering. Again, any questions with that, just an email away, let me know, and we'll get you squared away. All right, everybody, if there are no other comments or anything, we'll adjourn until May. All right, take care.
Thanks, everyone.
Thanks, everyone.